Hello everyone. I am myself Dr. Rajesh Gubba. I am the general medicine educator. So in this particular section, I'll be discussing a quick revision of the diabetic ketoacidosis. So this diabetic ketoacidosis, this is an acute complication in diabetes mellitus. And among the acute complications, apart from diabetic ketoacidosis, like what we have is hyperosmolar non-ketotic coma and then hypoglycemia. And this hypoglycemia, it might be because of increased dosage of insulin or inadequate food intake after taking insulin. And this diabetic ketoacidosis, it is characterized by the hyperglycemia, right? And along with the hyperglycemia, the ketone bodies, they will be positive. And then followed by that, there will be a severe form of acidosis. And this diabetic ketoacidosis, it results from absolute or relative insulin deficiency, right? It results from absolute or relative insulin deficiency, leading to uncontrolled lipolysis. There will be free fatty acid production, beta oxidation, then followed by that, the ketone body production. And this diabetic ketoacidosis, it is one of the important medical emergency. And in order to develop this diabetic ketoacidosis, there are some precipitating factors. And these precipitating factors include the infection. Because during infection, there is increased requirement of the glucose. Why? Because the glucose is utilized by the infectious organism for its growth. So the cell will not be having the glucose. So there is increased requirement of the glucose. And at the same time, if the glucose is not available, the cell will switch to the alternative source of energy, that is proteins and lipids, resulting in lipolysis and ketone body production. And the other precipitating factors is omitting the insulin or not taking the insulin, myocardial infarction, a severe form of stress, new onset diabetes mellitus. And apart from that, we also have the other precipitating factors like trauma and then psychosocial stressors, right? Psychosocial stressors. And we have euglycemic diabetic ketoacidosis, which can be observed with the SGLT2 inhibitors like dapagliflozin and as well as empagliflozin. Now, euglycemic diabetic ketoacidosis mean where the glucose levels will be within the normal limit, but the ketone bodies are being elevated. So this is the precipitating factor in case of DK. Then what is the pathophysiology in diabetic ketoacidosis? The pathophysiology is there is insulin deficiency. Right, pathophysiology is insulin deficiency. And along with that, there is also increase in the counter-regulatory hormones. What are the counter-regulatory hormones? Number one, the cortisol. Next, the glucagon. Next is catecholamines. Then we have growth hormone and thyroid hormone. So there will be increase in the counter-regulatory hormones. These counter-regulatory hormones, they increase hepatic gluconeogenesis and they further increase the blood glucose levels. Right? And at the same time, because the glucose is not available to the cell, even though there is increased hepatic gluconeogenesis, right? Because of the insulin deficiency, the glucose is not available to the cell. Now, as the glucose is not available to the cell, there will be alternative source of energy which comes into the play. There is activation of lipoprotein lipase. There will be excessive lipolysis, and that will result in free fatty acid production in excess quantity that will undergo beta oxidation, and that will result in the ketone body production. And these ketone bodies, they are acidic in nature and that result in metabolic acidosis. And the clinical features that you will have in these individuals will be nausea and then followed by that vomiting, and there will also be severe abdominal pain. Okay, so this particular severe abdominal pain, it may mimic the acute abdomen, but it resolves with the treatment. And followed by that, there will be like polyuria, and then the polydipsia, right? Polyuria, severe form of polyuria and then polydipsia. And this particular severe form of polyuria is because of the increase in glucose levels. And these patients will also have weakness and then altered sensorium and next to small breathing. And the breath, if you see, it is the ketotic breath. Okay, so it's a ketotic breath. So these will be the symptomatologies that you will have in patients with the diabetic ketoacidosis. And you will have the signs of dehydration, where the individual will be having the hypovolemia, dry mucous membrane, and there will be hypotension, there will be reflex tachycardia, and at the same time, there will be tachypnea. And next important is, these patients from the state of altered sensorium, they can go into a state of coma if they are not being treated. And the Kussmaul's respiration, it's a periodic breathing where there is increase in rate of respiration, and at the same time, there is also increase in depth of respiration, right? And the mental changes that are observed are mainly due to cerebral hypoperfusion. And what are the complications which are anticipated is the cerebral edema. Cerebral edema is one of the severe complications, especially in children. Right? Cerebral edema is one of the severe complications, especially in children. And this cerebral edema, it is caused by the osmotic shift during the treatment. Right? It is caused by the osmotic shift during the treatment. Right? Now, why there is an osmotic shift during the treatment? Now, you see here, let us just assume this is the neuronal cell, right? And the blood glucose levels are very high, and thereby there is increase in concentration of the plasma surrounding the neuronal cell, okay? There is plasma osmolality being increased. Now, what the neuronal cell will try to do is, now when the plasma osmolality is increased, there is a chance that the fluid from or the water from the neuronal cell may shift into the plasma. So, in order to avoid that particular shift, the neuronal cell will increase the solute concentration, right? Where there will be increase in the substance like taurine, and there will be increase in substance like myoinositol. By the increase of these substances within the neuronal cell, the solute concentration also increases in the neuronal cell. So, thereby the neuronal cell and plasma osmolality on a higher side. Now, let us just assume you have treated this hyperglycemia, right? You have treated this hyperglycemia first. What will happen? The concentration within the plasma will be reduced. Once the concentration within the plasma is being reduced, then there is a fluid shift from the plasma into the neuronal cell, resulting in cerebral edema. So, cerebral edema is one of the very important complications, okay? And it is a life-threatening complication that is observed in children. So, you need to be very careful whenever you are treating. You should not cause a rapid drop in the blood glucose levels. The blood glucose levels that has to be dropped should be gradual. And whenever you are also treating hyperglycemia, before treating hyperglycemia, IV fluids like normal saline has to be given, right? IV fluids like normal saline has to be given. So, very important is you need to monitor closely, very closely during the treatment. And the next important in the diagnosis, the triad is hyperglycemia, where the blood glucose levels will be more than 250 milligrams per deciliter. And then there will be metabolic acidosis, where the pH will be less than 7.3. And if you take the bicarbonate levels are less than 15 to 18 milliequivalents per liter, and then followed by that, the ketone bodies will be positive. And what are the ketone bodies? Acetone, acetoacetate, and beta hydroxybutyrate. And this ketonemia is very much essential for the diagnosis. The ketonemia is very much essential for the diagnosis. And this we were discussing about euglycemic diabetic ketoacidosis. Euglycemic diabetic ketoacidosis, this is seen in, right? So, this is seen in the SGLT2 inhibitors, right? So, in this scenario, the glucose levels will be within the normal limit, right? Normal limit in the sense, like where the glucose levels will not be in a state of decay range, the glucose levels will be in a range of less than 250 milligrams per deciliter. But the ketone bodies are positive, and there will also be acidosis, right? There will be acidosis. So, ketosis occurs without marked hyperglycemia. So, that is what is called euglycemic diabetic ketoacidosis. Now, in the ketone body testing, which is the predominant ketone body in DKA is the beta hydroxybutyrate. And this beta hydroxybutyrate, it does not get excreted in the urine. So, this beta hydroxybutyrate, it has to be tested in the plasma itself. It has to be tested in the plasma itself. And this particular beta hydroxybutyrate, it is not detected by the urine dipsticks, right? This beta hydroxybutyrate, it is not detected by urine dipsticks because it is not excreted in the urine. It is the plasma ketone bodies. That is the reason why the investigation of choice is plasma ketone bodies, not the urine ketone bodies. And how will you test the urine ketone bodies? You will test the urine ketone bodies, that is by urine nitroprusside test. Right, urine nitroprusside test. But this urine nitroprusside test will detect only acetoacetate. This will detect only acetoacetate. Right, so this will not detect the beta hydroxybutyrate. Done? Now, coming to the electrolyte abnormalities that you will have in these individuals is hyponatremia. Why there is hyponatremia is, please remember, for every 100 milligrams per deciliter increase in glucose, the sodium will reduce by 1.6 millimoles per liter. So, along with hyponatremia, there is chance for the hypophosphatemia and there is chance for the hypomagnesemia. So, there will be hyponatremia, hypophosphatemia and hypomagnesemia. Whereas the potassium levels, if you observe, the potassium levels, they are either normal or elevated. Right? The potassium levels, they are normal or elevated. And when do you think that the potassium levels will be reduced? The potassium levels can get reduced with insulin therapy, because the insulin is the one which will shift the potassium from extracellular compartment to the intracellular compartment. So, if you take the sodium correction, as just now as I was discussing, for every 100 milligrams per deciliter increase in the glucose, the sodium, it reduces by 1.6 millimoles per liter. Right? The sodium reduces by 1.6 millimoles per liter. So, correcting the sodium helps assessing the true water deficit. And this hyperglycemia causes dilutional hyponatremia. So, corrected sodium guides the fluid therapy. Right? Corrected sodium guides the fluid therapy. So, you should not unnecessarily give the excess amount of the fluids. So, you need to calculate what is the corrected sodium. And accordingly, you need to give the fluid therapy. And in the fluid therapy, the fluid that is being recommended is the normal saline or the ringer lactate. So, you need to give initial normal saline or ringer lactate that should be given in the form of bolus, right? After this, you need to adjust to 0.45% normal saline, okay? And along with this, that is after the supplementation of the IV fluids, then you need to add the insulin therapy, or you need to add the insulin infusion. So, whenever you are starting, you need to start with the isotonic saline. Then switch to hypotonic saline once they stabilized. And once the blood glucose levels drop to less than 200 milligrams per deciliter, then you need to add dextrose when glucose falls to prevent hypoglycemia during the acidosis correction. So, initially isotonic fluid or isotonic saline. Then followed by that, the hypotonic saline should be given. And whenever you are treating with insulin, right? So, you need to give intravenous regular insulin, right? So, you need to give intravenous regular insulin. And this intravenous regular insulin should be given at a dosage of 0.1 unit per kg bolus. Right? 0.1 unit per kg bolus has to be given first. Then followed by that, you need to give 0.1 unit per kg per hour. And this has to be given in the form of infusion. Right? This has to be given in the form of infusion. This has to be given until the acidosis resolves. Right? This has to be given until the acidosis resolves. Right? So, in case of mild DKA, in severe form of DKA, it should be like IV infusion. Mild DKA, subcutaneous analogs can be given. Whereas in severe DKA, you should avoid the subcutaneous insulin. Mild DKA, you can give the subcutaneous analogs, right? And next is the treatment of the potassium. So, the potassium levels will get reduced. Why? Because of insulin supplementation. Insulin is the one which will shift the potassium from extracellular compartment to the intracellular compartment. So, whenever you are treating the patient, what should be the aim for potassium is, the aim for potassium should be more than 3.5 millimoles per liter. Okay? And this potassium is life-threatening. Why it is life-threatening? Life-threatening low once the insulin is given. And once the potassium is less than 3.3, then you should give the IV KCl, because that can precipitate the arrhythmias and that can cause the severe form of the weakness. So you need to keep the potassium between 4 to 5 millimoles per liter. Then followed by that, the usage of the bicarbonate. Usage of bicarbonate is generally not recommended, but when the pH is less than 7 or when the bicarbonate levels are less than 10 milliequivalents per liter, that is when you need to give intravenous sodium bicarbonate. Okay, and this bicarbonate use, it may worsen if it is used inappropriately, and this bicarbonate may cause hypokalemia and as well as the tissue oxygenation, may worsen hypokalemia and tissue oxygenation. So that is the reason why bicarbonate should be given only when the pH is less than 7 and when the bicarbonate levels are less than 10 milliequivalents per liter. And next is the phosphate and as well as magnesium supplementation. Now, these patients, there is hypophosphatemia. The phosphate may drop with insulin, and severe hypophosphatemia can cause the weakness and as well as the hemolysis. So that is the reason why you need to supplement the phosphate if the serum levels are critically low, right? If the serum levels, if the serum levels are critically low, then you need to give the phosphate. Next is magnesium. So magnesium deficiency, it worsens the potassium and as well as the phosphate wasting. So you also need to supplement the magnesium if the magnesium is critically low. So phosphate and as well as the magnesium supplementation. And whenever you are giving the treatment, you need to monitor the vitals. You need to monitor the glucose. You need to monitor the electrolytes. Okay. So you need to monitor every 2 to 4 hours, right? The vitals, glucose, electrolytes, and then the mental status of the individual. So you need to monitor every 2 to 4 hours, and then you need to check the clinical status. And accordingly, you need to adjust the insulin, you need to adjust the fluids, and you need to give electrolytes accordingly, mainly to avoid the complications. So that is about the monitoring of the patient with the diabetic ketoacidosis. And what are the anticipated complications? I said you, like cerebral edema, mainly in children. Next important is the ARDS. What is the mechanism of ARDS? See, the severe acidosis, it will initiate the release of the inflammatory mediators like interleukin-1 and as well as the interleukin-6. The interleukin-1 and interleukin-6, this is the one which will be causing endothelial damage within the pulmonary capillaries, and that will cause the shift of the fluid from pulmonary capillaries into the lung, resulting in non-cardiogenic pulmonary edema. And the other complications which are anticipated is thrombosis and thrombotic events, and then infections. This is another important complication. And very important is whenever you are treating the blood glucose, you should avoid treating rapidly. So avoid rapid correction of the glucose. Why? Because the fluid from the extracellular compartment will enter into the intracellular compartment, resulting in cerebral edema. That is very, very important. So this is the important discussion related to diabetic ketoacidosis. Thank you very much.